be able to choose appropriate maneuvers for BPPV, and participants will be able to identify comorbidities that predispose patients for getting BPPV. So like Betsy said, we're concentrating a lot on vestibular stuff. There was a lot in this course. And of course, we know that the vestibular system is associated with concussion injuries and head injuries. So I'm going to give you some updates on that. So how do we diagnose post-concussion syndrome? What is the definitions? There's still really no clear-cut definitions. If you kind of look through the literature, everybody's kind of using different terminology. They're using different time frames. So how do we say this is an acute, concussion versus they're actually now into concussion syndrome? So some articles will say 1 to 2 weeks is the acute phase. Anything after that, and there's no spontaneous resolution in symptoms, then they've moved on into a post-concussion syndrome phase. Some will say it's after 3 months, and some will use it after 6 months. So again, we're still trying to weed that out in the literature, and that's kind of what they've proposed at the course as well. We do know that about 80 to 90% of concussions do spontaneously resolve on their own. So there's an estimated 10 to 20% of patients that will have post-concussion syndrome, and those are the patients that we will see and treat in rehab. And there's 225,000 new persons each year that show long-term deficits as a result of a mild traumatic brain injury. So again, those are the patients that we're capturing in our neuro rehabs and our acute cares and in the hospitals. Some prognostic indicators that are affecting recovery. Some literature had come out suggesting that if the patient presents with dizziness, so like let's say it's an athlete or after a car accident, they have immediate onset of dizziness, they're going to have a 6.4 times greater risk of prolonged recovery. So they might be at risk for having post-concussion syndrome, and that's a lot of what we treat as therapists in here is dizziness. Same thing if patient complains of blurred vision after the onset or the acquired injury, 1.5 times greater risk for PCS, and 7.3 times greater risk for prolonged recovery if they also have post-traumatic migraine symptoms. So sometimes we see this a lot too. Patients will go to neurologist or sports medicine with complaints of migraine, but we've also realized that they've had a hit to the head and maybe they didn't have these other symptoms, but now we want to kind of consider, did they have a concussion, and is this a prolonged recovery from that? So as far as a balance assessment, this was some interesting information that I wasn't necessarily aware of until we went to this course. We knew that the BEST test was a test that we would do for concussions patients. Sideline testing is a good, quick sideline test. I know a lot of our sports med doctors do it during their evaluations as well, our athletic trainers, those sort of things. But there's some research that has come out suggesting that the BEST test really is only valid to discriminate between concussion patients and non-concussion patients during the first week of onset of injury. So if we're seeing patients past the first week onset of injury, BEST test might not be your best, most valid discriminating balance test to perform. However, after 2 weeks, the BEST score was unable to differentiate between the concussed and non-concussed, like I said, but there were two specific conditions that they were able to differentiate, and that was the tandem on the firm surface and tandem on the foam surface. So if you're not familiar with the BEST test, basically what it is it tests your balance with your legs together, single leg stance, and tandem stance on foam surface and firm surface. Patient stands with their hands on their hips and eyes closed, and there's 6 types of errors that they get scored on for each condition. So if it equals out to 21 errors or greater, that will identify a concussed patient versus a healthy patient. Okay, so there's a need to do some more balance testing, which I think a lot of us who treat concussions do. Dual tasks is really important. There's some literature out saying now that instead of just doing like BEST tests or modified CAT-SIB, that we should be doing some dual tasking. So we kind of asked, is there any gold standard test? Is there any significant testing that we should be doing? And what they seem to be doing at UPMC is just some gait exercises with cognitive tasks. So there's really nothing too gold standard yet, but we do have the DGI and we do have the FGA that does dual tasking. So that's kind of what we've been using here at 8th Avenue. But dual task balance assessments demonstrate prolonged impairments compared with a single task. And dual task gait individuals with mild brain injury had more difficulty with changing directions and using visual feedback to navigate obstacles. So again, the spatial awareness and navigation. So that's kind of where I think the FGA and the DGI play a good role. So vestibular rehab following concussions. CHOP did a study, so the Children's Hospital of Philadelphia, to see if a patient complained of any vestibular deficits, how long it would take them to return back to activity, and it was significantly a longer period of time. And so you can see on the slide there the bullet points. Return to school, the median days was 49 days versus 6 days for somebody who didn't have any vestibular dizzy balance complaints. Fully cleared, back to school, median days, again 106 versus 29. Return to, I think that's supposed to be, this is, sorry, I don't know what happened there, but it got duplicated. I will get you the numbers for return to activity, and we'll send that out through email. I apologize for that. Okay, vestibular ocular motor screening, some updates here. So the VOMS, that's what it stands for. This actually comes out of the University of Pittsburgh, and MUCA has done a lot of research in ocular motor screening and assessment. So the VOMS is a simple short screen that assesses 5 domains. So we're looking at pursuits in the horizontal and vertical direction, saccades in the horizontal and vertical directions, near point convergence, VOR in horizontal and vertical directions, and visual motion sensitivity. So after each domain is performed in your assessment, the patient rates on a scale of 0, 1 to 10, so like a visual analog scale, what their headache is, their dizziness, nausea, and fogginess. So Ann Muka, who, like I said, is at the University of Pittsburgh, her and her colleagues came out with a study and indicated that a VOM score of greater than 2, near point convergence distance greater than, so if there was like 2 or more positives, patients were symptomatic with 2 or more of the VOMS domains, their near point convergence was greater than 5 centimeters. That was significant that patient would likely have post-concussion syndrome at the time of after the assessment. 3 VOMS items, VOR, VMS, and near point convergence resulted in 89% accuracy for identifying patients with concussions. And then abnormalities on the VOMS are associated with delayed recovery. So central versus peripheral. So after a patient sustains an acquired head injury or they have a concussion, they're diagnosed, do we know if it's a central vestibular issue or is it a peripheral issue? Could be a little bit of both. So there was one study that was done where they did a head impulse testing, negative head impulse test in 56 subjects following concussion, normal head impulse in sample of veterans following a mild traumatic brain injury. So that's suggesting that really it's more of a central issue versus more of a peripheral issue. So it's more likely central, so we have to manage it differently than we would a regular peripheral vestibular issue. Often there's a migraine overlay that's working as a comorbidity and protracting that recovery. And we want to take more of a habituation approach to treatment versus our regular peripheral approaches that we would take. So visual motion sensitivity. There was a lot of talk about this, which was interesting because I haven't always thought about this either. But Visual motion sensitivity is there's an uneasiness created by a situational stimuli. So patients will come into the clinic and they'll say, I get really dizzy if like somebody walks by me quickly, or if I'm in a crowded area and there's a lot going on, or there's busy patterns on the wall. I basically just need to sit like in a quiet, plain, dark room. It might be because they're having some visual motion sensitivity issues. So again, that optokinetic hypersensitivities, their eyes aren't working well to focus on things around them when there's a lot in their environment to take in. If ongoing, it may lead to spatial and motion discomfort, what we're calling visual vertigo, or chronic subjective dizziness, or another kind of disorder called 3PD, which is kind of a prolonged vestibular deficit, but also leads to anxiety and a lot of other psych issues as well. So those all need to be managed a little bit differently than we would a regular patient with like a hypofunction or a labyrinthitis. So again, treatment methods would be habituation, so just re-exposure to that noxious stimulus in a gradual fashion, expose, recover, and eliminate avoidance behaviors. So this is kind of a big thing too. We've been really trying to target with our patients. A lot of times the patients are having visual sensitivities, like the sun hurts their eyes, or they'll wear sunglasses. Any kind of sensory sensitivity, loud noises, that wear earplugs. We're trying to get them out of these avoidance behaviors because all they're doing is teaching their brain how to compensate, and they're never kind of re-exposing themselves back to this noxious stimulus. And so we're doing a lot of education on that and trying to get patients to wean themselves from these compensatory strategies. So, and then just some vestibular comorbidities, how some other diagnoses can, affect how we're going to treat the vestibular system. There's a lot that coexist, and I mentioned this earlier with migraine and or anxiety. So a lot of times patients might feel dizzy because of a migraine or anxiety. Isn't necessarily vestibular related, so we have to do a good job of weeding that out and dealing with referring providers and looking at medications, and again, are the medications that they're getting provided for these issues, are they causing the dizziness as well? So there's a lot to consider in that respect. And then there's mood. There's obviously mood changes. 11 to 31% of children with will develop an anxiety disorder within the first 6 months if they have post-concussion syndrome. So it's another thing that we want to make sure we're screening for, that we're looking out for, that we're getting our patients help with, or teaching them strategies to deal with. There's going to be, if they had, a pre-injury depression and anxiety, they will experience more of these deficits, or it might be heightened. So especially if you're dealing with children, you want to make sure that their parents are looking out for them to see if they're still having normal behavior. Are they behaving well in school? Are they getting good grades? Are things dropping? Same thing with your middle-aged to older patients who might be having trouble at work, or they just don't feel like doing the things that they want to do anymore. We need to make sure we're just taking all of these things into consideration. All right, and concussion and ocular motor dysfunction. So again, we talked about the VOMS, which assesses ocular motor dysfunction and how it's going to help us in our diagnosis and to identify those patients that might have a prolonged or protracted recovery. It should be standard part of an exam, so like we said with the VOMS, but also any sort of ocular motor you can do would be good. We need to then adjust our goals and our time frame for rehab based off of the findings, obviously. And an important message that we took back from this, and we kind of already knew this, but sometimes we see it happening where patients don't always get a full ocular motor exam to weed out like central causes and peripheral causes. But if your eyes are not working together, if you don't have conjugate eye movement, if you don't have good eye-eye coordination, it's going to impact your eye-head coordination, which is part of the VOR, the part of the vestibular system that we're focusing on as physical therapists. The eye-eye coordination, a lot of times we rely on our occupational therapist to help us with that as well. But if you're trying to get your patients back to sports and using good eye-head coordination, if they don't have conjugate eye movement, that's really going to protract their recovery, and then they're not going to get that eye-head coordination. Kind of makes sense? Yeah? Okay, good. She's nodding her head, so that makes sense to her. All right. And then lastly, what's the role of positional vertigo in concussion? So it's very low incidence, surprisingly enough. In a sports-related concussion, it's less than 5%. But if people are going to get post-traumatic BPPV, it's most likely going to be more complex than an idiopathic BPPV. And some of the things that I list down there, it's more common in people older than 30 years old. It's going to be twice as more likely to be bilateral versus just unilateral. If it's just an idiopathic BPPV, it's 3 times more frequently in multiple canals. So instead of it just being your easy posterior canal lithiasis, you might have it in, horizontal and posterior on different sides. So making sure you're testing all of your canals is really important if you think that your patient is going to have BPPV. And there's going to be greater symptom severity because, again, there's a lot of other things going on. We have anxiety, migraines, dizziness, balance, central and peripheral causes of dizziness now. So it's a little bit more difficult to treat. Any questions? Yes, Steve is raising his hand.
So if it's anterior on the left and posterior on the right, what are you going to say?
Well, you'll see the same thing, and it's a good question. I would treat the side that's more symptomatic for the patient.
So what are you going to see? Wouldn't that counter each other?
They do counter each other, but you'll still see the rotation going to the side that's affected. Yeah, so their planes are in the same, but the nystagmus will go towards the side that's affected. Yeah, well, you might see it, you'll be positive on both sides, but it's just the way the rotation of the eyes are going.
You're saying if you have a left posterior and a right anterior,
yeah.
where your eyes going to be?
Yeah. Yeah, you're going to get a...
Like if you're going to the right.
I would say whichever one's pulling harder, with the direction
yeah.
is going to be going. Be like a horizontal canal.
Yeah.
Both directions.
That's why it's complicated. Yeah. It's a good question. Yeah, it's a good question. And you can sit and think about it, but once that patient comes into, you have no idea. You're just going to, yeah.
I know I give her the posterior first to be really sure that I really have it.
Yeah. All right. So that's it for the concussion part of the vestibular update. Betsy's going to do the BPPV part of it then.
So that was a great segue into talking about BPPV. So if you have had a concussion and then you get BPPV, that's an obvious reason that you would get BPPV. But for the most part, it's idiopathic as to why somebody has gotten BPPV. But so they still don't really know why everybody's getting it. But there's definite comorbidities that lead people to getting BPPV. So let's talk about it. So the first comorbidity that I think it has the most research behind it is diabetes. So they did a study of everybody, a sample of patients that have BPPV, and 46% of those persons had diabetes. So that's almost half of the people. So that's pretty significant. And then 42% of the association between type 2 diabetes and BPPV was mediated by hypertension. So 42% of that population that they took not only had diabetes, but they also had hypertension. So the big take home there is if you have a patient that's dizzy and they have diabetes and they also have hypertension, you should probably be doing a screen for BPPV no matter what, because there's a really high likelihood that they do have it. Or if you're seeing a patient for a different reason, and they have both of those predisposing factors, and they mention that they're dizzy, even if that's not the reason why you're seeing them, it's probably not a bad idea to screen them. So just take a quick look at that picture of otoliths at the bottom of the PowerPoint, because they're really nice looking in that. And then we'll go to the next one. And if you look at the otoliths in this picture, those are otoliths that have aged and are, possibly osteoporotic, and they're breaking down. So some of the theory is that possibly it's obviously people get BPPV more often when they age, and it could be that their otoliths, just like bones kind of break down, they also break down and degenerate. So there's a pretty high correlation between BPPV and osteoporosis and the occurrence and recurrence. So there was a study done, and persons with osteoporosis had a 1.8 greater chance of having BPPV compared with a control group. And kind of along with that, there's more studies that had done, and the odds of having BPPV when having low vitamin D are 2 to 1. So again, if you have a patient that's dizzy and they have osteoporosis, it's probably worth just checking them for BPPV, even if their symptomology or symptoms don't sound like that's what it necessarily is. It's probably no loss to just screen them and check them for positional dizziness. The next thing to talk about is BPPV and falls, because I think there's a tendency to think that it's benign. It's benign paroxysmal positional vertigo. It's not hurting anything. The patient's just dizzy when they're changing positions, but essentially it doesn't bother them in any way. But BPPV definitely can cause falls. So 64% of reported elderly fallers with BPPV reduced significantly with fall rates after having the Epley procedure done. So it's really important to make sure that we treat the BPPV. If somebody's dizzy and they're having falls, it's really important that we make sure they don't have BPPV, and if they do, we really try our best to kind of get rid of it for them and make them aware of symptoms. So if it comes back again, get them in to see their physical therapist and have them have the maneuver done so that they can reduce their symptoms and hopefully keep them from falling. Because as we've saw, most of those people are going to have osteoporosis, and they're going to be diabetic, and they're going to have other comorbidities that if they fall and they hurt themselves, it's going to be a major problem for them. So there's something called subjective BPPV, and I'm sure a lot of people have seen somebody like this before, and they've actually done a study to try to figure out how we're supposed to treat them. So 87% of patients with subjective symptoms of BPPV and test positions that did not have nystagmus did improve symptoms with maneuvers. So the big take home here is treat subjective symptoms of BPPV the same as you would treat someone with a visually observed nystagmus. So I've kind of changed my practice knowing this as well. So I used to think if I saw somebody that everything followed like BPPV, if I put them in a Dix-Hallpike or a roll test, I didn't see a nystagmus, I would say it's not BPPV, and I might treat them like a unilateral hypofunction. But this study is showing that 87% of patients do get better with maneuvers if they have the same symptoms as somebody that have BPPV. So testing positionally, they get dizzy, it goes away. Is following the same pattern. And I would say, and I don't know if any of you guys agree, that after having treated those people with just subjective symptoms of BPPV, I do see a lot of people getting better. I think that this is a tricky thing to treat because sometimes we think somebody might have BPPV, they have this subjective maybe symptoms, you treat them a time or two with maneuver, they don't get better, and then it's kind of like, I think there's a gray area as to where do I go from here if they're not getting better with positional maneuvers, and then you might want to restart. So usually the rule of thumb that we stick to here is 3 sessions of trying to treat them, or and then if they don't get better after that, then kind of go to plan B and see what we can do from there. So what we do want to go over also today is just maneuvers for each of the canals that you might see BPPV in. So estimated frequency of posterior canal BPPV is 81 to 89%. So this is going to be the majority of everybody that you see is that just has a posterior canal BPPV. So typically people think of, we use the Epley maneuver for a canalithiasis and we use a Samant maneuver for acuculolithiasis. But really in reality, both maneuvers can be used for posterior canal. They have equally effective rates with similar recovery and similar recurrence rates. And there might be an advantage to doing the Samant because 7.8% of Epley maneuvers converted to horizontal canal BPPV versus 0% were Samant, with the study that was done to kind of compare the both. Now, Epley maneuvers are obviously easier to perform than a Samant maneuver, and so that might be the advantage. And I think here at 8th Avenue, what we tend to do is do the Epley first, and if it doesn't work, then we try a Samant. And knowing this information, be much quicker to kind of switch to a Samant if your Epley's not working. We'll kind of go through some other maneuvers that are out there as well too. There's another newer one called the Lee maneuver. It came out in 2017, and with a study done by Lee, there was no difference in outcome with Epley versus Lee maneuver. There's only one study about this maneuver, But as you can see with the directions below, it's much easier to complete on somebody. So they're lying on their side, they're facing forward on the affected side, and then you switch them over to the unaffected side. Again, just facing forward with their head, no rotation at all. So this is a good maneuver to use for somebody that might have a lot of neck pain. They can't get a neck extension because they can just stay neutral and flip right over. Again, kind of going back to if you've done an Epley, it hasn't gone better. You've done a Samant, it hasn't gone better. You can try doing a Lee maneuver. Another new one is the Gans maneuver. So the subjective and outcome measures are at 47% versus 70% for Epley. This is just another one you could try if somebody has a lot of cervical pain. Even back pain, this one might be a little bit better just because they're kind of doing log rolls and not such a fast kind of up and down in between compared to the Samant or the Epley, but not as good of effectiveness ratings as the Epley or the Lee. So the the other maneuver that we learned, newer one that we learned at this course, is called a Samant Plus maneuver. So it's basically, this one you would use for cupulolithiasis versus a canalolithiasis. In this one, you're basically doing the same thing as a Samant, but instead of just coming right down under the table, you actually bring the patient's head 20 degrees below horizontal with a hold of at least 45 seconds. And supposedly it improves the movement of larger crystals in vitro models. We've tried this with a few people in here, and by the time you're having somebody do a Samant maneuver, most of the time those people are able to tolerate it, and obviously this would be a tougher maneuver for an older person or somebody that's very sensitive to position changes because they're bringing their head all the way off the table, and it's just obviously it's anxiety provoking but also symptom provoking. We unfortunately could not find a video for this anywhere. Okay, so we were going to try to demonstrate it. So we're going to roll over here. I got to use the table, I'm sorry.
Yep. Sorry.
So if you guys, we're going to do it right over here. Oh, no, it's okay. Let's stop the presentation so I think you can see the head of that right there. I'll just start over here. So you start the maneuver. Kristen's just going to show the point as to where you would bring the patient's head off the table. So you would start this, you do it exactly like a Samant. It's just when you're coming over to the point where you're bringing their head kind of like it's face down on the table. We'll skip ahead to that. Right.
Oh, we're going all the way up.
Well, all the way up and over, right?
Yeah.
Right.
Yeah, sure. 1, 2, 3.
Over, and then we're going to take it off.
Yep. And so you do the same thing. You'd wait till dizziness goes away. You're holding 30 seconds, and then that's it. And then sitting back up again. So,
And you're cured.
and you're cured, hopefully. So that's the Samant Plus. Okay, I'm not moving anymore. All right. The next thing we'll talk about is the horizontal canals. Horizontal canals tend to be the trickiest, I would say, to get better and also to diagnose. But we're going to talk mostly about the things to get better and not necessarily the diagnostics of it. So at this point, the most highly recommended maneuver for a geotrophic nystagmus for a horizontal canal would be a Gufani, or sometimes people call an Piane maneuver. The BBQ Roll is kind of what people, I think, are more familiar with, but this tends to be easier and has a higher success rate, or a very similar success rate, and it's comparable. Check out the next slide. So I don't know if anybody's familiar with this. So it's similar to a Samant, but not as complicated. The patient comes down, lies on their side, then their head is turned towards the table, held there till symptoms go away, plus 30 seconds, then coming back up again. There's some debate as to how long the holds are, and it kind of depends on who you read on that, but typically Betsy, does like a 30-second hold just like I would do for an Epley. Since there's debate, I stick with that. So the Kim maneuver, is a different horizontal canal maneuver, but this one is supposed to be for cupulolithiasis. It has a 97.4% success rate within 2 maneuvers. There's a little stereocilia with a otolith attached to it. It's kind of a cool picture I was excited about. It's unrelated to the Kim maneuver. Let's look at the Kim maneuver. So this maneuver, you could there's 6 positions. This one involves vibration. So we have something we use for vibration here. They, at the clinic where we watched them do these, they had like a massager to use for vibration. There is some debate as to whether vibration is helpful or not, and I believe there's a study out there saying it makes no difference whether you're using vibration or not, but this specific study was used using vibration, and so I included it because that's how it was done. This is what we use for putting vibration in somebody's mastoid. We did have some success using this with one patient so far. Horizontal canal isn't that common, but I will say it worked well for that patient, so that was good. So I quickly want to just talk about null point. So when you're testing somebody's horizontal canal, if you think about it, at some point in time, there is a point where their stereocilia are basically just hanging with gravity. And so in the way that the otoliths are going to fall, it's not going to affect how the stereocilia move. So it's about 10 to 20 degrees in the transverse plane towards the involved side. And then it'll be the cupula of the ipsilateral horizontal canal on the other side. So it's basically 180 degrees one side versus the other. So the reason to mention this, I think, is to make sure that when you are checking somebody's horizontal canal in the roll test position, make sure you're rotating well past 20 degrees because you want to make sure you're triggering it. If you don't go past that 20 degrees, you might be sitting at somebody's null point, and then you're not seeing that they have an nystagmus, or you're not hitting their symptoms because you're kind of hanging out where they're not going to have symptoms. You can use this to help diagnose sides and all sorts of things, but I think the big thing to remember is to make sure you're rotating somebody's head enough because a null point exists. And then anterior canal BPPV. Anterior canal BPPV may have an incidence of up to 3%. There's absolutely no controlled studies to date actually identifying anterior canal BPPV. The 2 recommended maneuvers, if you really think it is anterior canal, would be either an Epley or a Jacobino maneuver. I don't have pictures of those included, but if you have more questions, you can always send an email to ask. And that is it. Does anybody have any questions for me? No? Anybody online with any questions? Nicole is typing a message. Yes, I can email out the slides, sure. Anybody else? No? All right. No, any questions for Kristen either? Everybody's good? All right. Cool. Well, thanks for everybody for coming. And, Lauren's got a question. Oh, thanks. So hopefully the next lecture will be in January, so it's going to be every other month. Oh, I'm sorry, in November. Steve's giving me looks. It's going to be in November, and hopefully for the November lecture, we'll have CEUs available as well for online or for coming live. And this lecture will be available online, but not for CEUs yet, not this one. Anything else?
New Jersey is still live only, once we decide that one.
New Jersey is going to be live CEUs only available in person for now. All right, thanks everybody.